Domestic violence survivor. This case presentation's agenda will include demographics, key findings presenting problems, client view of the problem, background precipitating factors, formulation assessment, interventions and plans, and reasons for presentation. Demographic. The client is a 32-year-old woman, cisgender woman, who is female assigned and identified survivor of domestic violence who uses she, her pronouns, is bisexual, and is reconnecting Laguna Pueblo Indigenous and Irish German of working poor status. Client was put into foster care at 9 years old after initially living with her paternal grandmother when removed from her biological parents. Client's foster family is Pentecostal and raised Client as such, though currently she identifies her beliefs as being spiritual. Client has emotional disabilities, schizophrenia, post-traumatic stress disorder, PTSD, and bipolar depression. Key findings presenting problem. Client used substances before, meth and fentanyl, and sleeps in her vehicle at night due to symptoms from her emotional disabilities of schizophrenia, PTSD, and bipolar depression, causing the client to believe her housing per the agency is unsafe. Client has auditory hallucinations that trigger her PTSD and bipolar depression. Excuse me. The voices she hears tells her that someone will break into her apartment and she will be raped. Client view of the problem. The client believes her auditory hallucinations stem from her substance use in the past, abuse endured as a child by her biological parents, and because she has yet to come to terms with having schizophrenia. Client feels that if she develops coping mechanisms, the stress will be lessened and she will be able to get on Social Security, supplemental security income, and work 25 hours a week, as well as feel safe enough to sleep in her home. Background precipitating factors. Client was removed from her biological parents because they had substance use disorders, were neglectful and physically abusive. Client's father was diagnosed with schizophrenia, and the client doesn't know about her familial psychiatric history beyond that. The client experienced child sexual abuse, CSA, twice by her maternal uncle under her biological parents' care. Formulation assessment. The client's symptoms are manifesting because the client's established routine was abruptly changed, making her limited behaviors more pronounced. The client's negative thoughts are also biological. The client understands that her emotional disabilities are the root of her behavior, but may not understand how she can modify her thoughts and beliefs to have more beneficial behavior. Cognitive behavioral therapy theory, quote unquote, suggests that our thoughts, emotions, body sensations, and behavior are all connected, and what we think and do affects the way we feel. Using this theory, I will help guide the client, quote unquote, through steps to understand her behavior, including the thought processes leading up to her behavior, even when thoughts are related to schizophrenia, PTSD, and bipolar depression. As a short-term problem-focused approach, such a method will help the client learn a variety of coping skills that will assist with managing difficult situations by, quote unquote, teaching strategies to modify negative thoughts so the client can respond to the thoughts differently, while also teaching how to test reality of her thoughts and perceptions, ignore any distressing voices, and manage symptoms. Interventions and plans. An intake was conducted where questions related to the presenting problem, the assessment of her current mental health status, and the biopsychosocial assessment were done. Her treatment plan is to maintain medication intake and utilize CBT modified for psychosis techniques, mindfulness, and coping mechanisms by way of solution-focused therapy to deal with the voices she hears and her thoughts. We have implemented some modified for psychosis CBT techniques where I have taken the role of a coach and employed strategies such as changing the topic, enhancing support, narrowing the focus of conversation, and using breathing meditation techniques. I will also incorporate change talk and instances where a successful solution has been achieved by the client. Utilizing psychosis modified CBT, PCBT, will decrease episodes of psychosis, quote unquote, improve therapeutic alliance, reduce stigma related to psychosis, build skills to self monitor and manage symptoms, reduce reliance on medication, and promote recovery. Mindfulness integrated with PCBT is being utilized because it helps to, quote unquote, alter the global properties of the whole family system, specifically cohesion, conflict, organization, and control, which in turn have an impact on reducing the client's psychopathology. Done in short durations provides the opportunity for the client to, quote unquote, not get caught up in rumination about psychotic experiences and experience them as being part of the client's everyday life that are responded to in the same way other experiences encountered are during therapy. Solution focused therapy will help reduce the client's stress, highlight her strengths and inner resources, as well as allow the client to approach her desired outcomes, aka her goals. Reasons for presentation and two questions. I selected this client and her case over others because the client has met the most with me and we've built a therapeutic relationship. The client also is ready to address her presenting problem, evidenced by the number of times we've met. The chance to focus on the business of the 43-year-old agency, the domestic violence shelter that I work at, wasn't a viable option due to the inner workings of the agency being too complex with frequently changing leadership and a lack of transparency. I believe presenting this client's case will result in suggestions that I can use to assist this client as she presents a uniquely complex problem. Two questions. How do I address the client potentially missing her appointment? And what other theories could I utilize to assist this client? Many thanks. And here is my bibliography. Thank you.